Welcome to the Waiver Assessment of Modalities of Services webinar. It's my pleasure to introduce Jan Tice. Now I would like to turn it over to Jan to begin the training.
Thanks, Kimberly. Good morning. Welcome to our webinar on waiver assessments modalities. Well, I want to start by saying I really hope everyone who's participating as a participant in this webinar is safe and sound, and those you care about are, and know that, certainly myself, and I think I'd speak for everyone at CIBHS, that anyone in the areas of California that are having, experience with these fires are safe and sound. So just thinking about that and had to start off with that. And I want to encourage all of your questions. You can type them in at any time, and I'll pull up questions once in a while and try and certainly meet your needs. So I'm going to start. This is an assessment of modalities, and certainly talking about the waiver, the Drug Medi-Cal Organized Delivery System, also referred to in this as ODS, really talks about, and certainly a vision to have a integrated continuum of care for those affected by substance use disorders. Many of the elements we'll talk about today are contained in the waiver terms and conditions, also sometimes referred to as STCs, the standard terms and conditions. And so we'll talk about what are those terms and conditions that affect the services, the modalities of services offered, look at data sources that we may use existing and ones we may need to support the evaluation of this waiver, and look for how we would plan to fill in gaps in services as we recognize. At the kind of cornerstone and foundation of waiver ODS services is the ASAM, the American Society of Addiction Medicine. The criteria are the standardized evaluation tool for assessing people and moving them through, and in fact for treatment planning and the levels of service. And of course, there's a few up on the slide, some of the principles of the ASAM, and one talks about really being program versus clinically and outcome driven. And for the most part, substance use disorder services have been recognized as being program service. Certainly clinical issues have been addressed within the program context, but what this really talks about is that the clinical needs and the preferences of the participant in the program, the client, the patient, as your program might call them, really drive the length of stay, which is the second point, that instead of a fixed length of stay, which would be program-driven, 28 days, 90 days, 12 weeks, we look at variable length of stay that would be determined by the participants, the beneficiary's response to treatment. What it means is some may stay shorter than what would be the traditional looked at program length of stay. Some individuals might have to stay longer. It's a variable. And look at a limit, instead of a limited number of levels of care, we have a broad and almost flexible continuum. So really look at in a continuum of care, it's not only the substance use disorder, integrated with this would be primary care and mental health, and multiple options to meet the individual client needs. Also in this was to clarify treatment goals and focus on outcomes. And again, this is an idea and a principle which drives the variable length of stay, that when you have you admit someone into treatment and identify what are the relevant strengths, abilities, needs, that you identify treatment goals. And these goals, oftentimes you'll have long-range goals and wellness, and some of the short-term goals may really be discharge criteria to another level of care. The levels of care that are identified in the STC and in the waiver. I'm just going to briefly go through these. There's a handout that you can download off of this webinar that gives more of flesh to the skeleton. I'll put out that the level 0.5 is an early intervention level of care. Actually, it's not even looked at really as a level of care, but it's certainly a level of intervention. And one of the doors, all doors are open into this system of care. The earlier intervention mostly talks about SBIRT, the screening, brief, intervention, and referral for treatment. Frequently, that SBIRTs are provided in the medical realm, and it has as component screening where a primary care physician or a health professional may screen an adult. Actually, they could screen you. But screen them for alcohol or other drug misuse, provide a brief counseling intervention, and a referral to treatment if, in fact, it looks appropriate. There are other levels of prevention, and none of them, even this SBIRT, are funded directly through Drug Medi-Cal. They have other funding streams, but it's certainly a requirement for counties to have this level of early intervention. Treatment really starts with a level 1 outpatient, and that is for adults up to 9 hours a week, and for youth up to 6 hours a week for adolescents. And outpatient, of course, people come a certain number of hours a week scheduled in. They may include the components of, certainly, intake, the process of the evaluation and assessment of the individual for their substance use disorder and treatment needs. This is frequently intake, even though some counties may have a centralized intake type of a system or referral system. Intake is still required at the agencies, and frequently this is for medical necessity, the elements, the important identification of impairments that would be treatment planned would happen. Individual counseling is a component, and group counseling. There's a requirement in the group counseling that it can be 2 or more clients, but no more than 12, and it focuses on the needs that are identified in treatment planning and recovery. Family therapy, patient education, medication services, which may include the prescription assessment of individuals for medically assisted treatment, collateral services, which, as opposed to family, would include people other than family, but who have a very strong ongoing significant relationship with the individual. Crisis intervention is a component, and of course treatment planning, developing the treatment plan, and discharge services of discharge planning. I've said a little more to you. Of course, there's more to those, but these are what I call identified billable components that may be in the 9 hours or less of an intensive outpatient program, or excuse me, of an outpatient program. The next level of care, the 2.1, is intensive outpatient, which is 9 to 19 hours for an adult or 6 to 19 hours for an adolescent. And it's composed of the same elements that are billable elements that were included in my review of the outpatient. So again, the intake, individual group counseling, crisis. These can be included in the 9 to 19 hours. The next level, now these two, as it's marked on your slide, required, meaning that for any county that is joined the Drug Medi-Cal ODS Waiver option, is required to offer these services in their county. So the early intervention, the outpatient and the intensive outpatient are required. An option is a partial hospitalization, and that's a level of outpatient care, which is the highest level of outpatient care, and it's 20 hours or more of clinically intensive programming a week. And typically in the partial hospitalization, patients would have direct access to psychiatric medical services. And again, it may be someone who's integrated with the program and available on site. It may be through a contract or a referral, but is that higher level of medical, psychiatric, mental health available. And this is pretty much a theme in the levels of care as the intensity in terms of the hours of service are increased. In the modality, the severity of the presentation of the symptoms or the impairments of the participants also increase. So and generally you see that in dimensions that are around medical, psychiatric. So as services and staffing has to bring in more of the professional staff. Residential treatment has several levels, and one level of the 3.1, 3.3, or 3.5 is required in the first year. And that first year starts with the counties initiating their program, having it accept their proposal for their waiver services. And the lowest level is 3.1 residential treatment. Typically, of course, needs to be a licensed alcohol and drug facility, licensed by the state of California, and all of these need to be drug Medi-Cal certified to be a provider. It's a short-term residential program. If you go into the ASAM manual itself, it would say this level of care could offer 5 hours, typically 5 hours or more of clinical services by professional staff a week. However, certification really requires 20, and when I've looked at several of the waiver programs in various counties in that level of care, they do require their providers to provide 20 hours. It's a structured pattern of activities, typically intended to restore the cognitive functioning, build patterns of behavior which will support recovery, and hopefully sustain abstinence and engage the individual in continuing care and recovery. The length of stay in any of these residential services by the waiver, now counties can always be more restrictive than waiver requirements, but never less restrictive. And this is the only area of residential treatment by the waiver language has what's called a capitation, or a limit on the length of stay or the number of experiences. And that is, for an adult, they can get up to 2 non-continuous 90-day treatment episodes in a year. And one of those episodes can have up to a 30-day extension. That's our status right now. That's true for all the perinatal clients may receive a longer length of stay, though, but it's based upon their pregnancy postpartum status. Residential services for adolescents are limited to 2 30-day regimes in a 1-year period. They may also have a 30-day extension. And the components of the residential treatments are the same as for the outpatient, intensive outpatient. Again, the group, individual, crisis. These are the recognized, and let's say if a program were a 3.1 and required to provide 20 hours, those 20 hours could be comprised of any mix of the group, individual, crisis, intake assessment. Those all could make up the 20 hours. The next level of care to that is the 3.3, which is a population specific, and that one is targeted to people with cognitive functioning issues, maybe traumatic brain injury would be a common one, which require treatment to move at a pace that recognizes maybe some of their limitations on processing information and their cognitive functioning. The level 3.5 is a higher intensity residential treatment. I've seen again in some counties, while ASAM and the waiver doesn't really speak to the number of hours of services within the 24-hour residential. Some counties I've seen increase the hours that are expected of service in high intensity residential. This again is always up to your county's plan that was submitted and approved. But the higher intensity residential certainly would be expected to have increased staffing that is licensed, certified, increased connection and the integration with any mental health and substance abuse or mental health and primary care. You'll see in these programs, all of these programs, 3.1, 3.3, and 3.5, they're all called clinically managed services, which means they may be directed by a physician, but the physician is not providing services directly in the program. So that's where you have a medical director, and the management of the program is mostly by licensed and certified alcohol and drug staff in terms of providing services. That would vary. That would be different from when you move into the 3.5, the higher intensity residential, which will be required by year 3. Excuse me, the high intensity 3.7 is a medically monitored, and that's where services are provided by an interdisciplinary staff that might include nurses, counselors, social workers, addiction specialists, and have available for monitoring physicians, and would be under the direction of the physician, but they would have that ability to monitor patients' medical and psychiatric care 24 hours. When we go to the level 4, the medically managed inpatient, that's where the services that involve the daily medical care are provided right on site, and instead of just being monitored, and someone may go somewhere else for treatment, medical condition assistance provided on site. The levels 3.7 and 4 has to be coordinated through agreements. These are provided agreements, and they may be agreements in the county itself or regional agreements. And these services are generally provided at acute care hospitals, psychiatric units, and one of the very few, what's called a CDRH, chemical dependency rehab hospital. And this is a very high level of care that it's difficult to find, and sometimes people need them. So these are the services we use sparingly. Drug Medi-Cal does not fund the 3.7 or 4. These are through a fee-for-service Medi-Cal. And I should, before I leave this slide, say that the 3.1, 3.3, and 3.5, in the first year, a county only needs 1, but all 3 are required by year 3. Also, we move into opioid treatment is required. This is services provided in a narcotic treatment licensed facility. And it's not really a variance with how narcotic treatment programs have been in the past. It's just really saying this is a required level of care. And withdrawal management, the next level, at least 1 level is required, and there are 5. 2 of the levels of care, 1 and 2, are ambulatory withdrawal management. That's an outpatient One is without extended on-site monitoring, and the second is extended. And so it really almost compares to outpatient and intensive outpatient. This slide has not funded by direct Medi-Cal, but I've been seeing some counties that did get approvals, certainly LA County, and is using funds to fund the levels of care. In fact, down to the 3.2, 3.7, and 3.4, the medically monitored and managed is not. So you have two levels of ambulatory, so it's outpatient and intensive withdrawal management and a less intensive withdrawal management. Of course, the severity of the withdrawal and the risk the person would have in terms of medical compromise in the withdrawal would be driving any decision on what level it would be. Definitely the level 1 and the level 2 are an AOD certified non-residential detox service authorization. They have to have drug Medi-Cal outpatient certification and detox service certification. The 3.2 withdrawal management is typically what we used to call our social model detox. It's a residential inpatient clinically managed. So again, you don't have the medical staff in there monitoring or supervising withdrawal management. It's 24-hour support for complete withdrawal, and it's generally in a DHCS licensed residential facility with detox service authorization and DMC residential certification. The levels 3.7 and 4 are medically monitored, again, where you sometimes have a nurse who monitors, maybe a physician who stops by and monitors, but treatment for any medical complications is not provided. The level 4 would definitely be an acute care hospital, and it's medically managed. There are additional levels of care offered, and the important one is the medically assisted treatment and MAT, and there's an expansion of not only for opting counties of buprenorphine, naloxone, disulfiram are going to be reimbursed for not only on-site administration and dispensing in MTP programs. Physicians and licensed prescribers in other drug Medi-Cal programs can be reimbursed for the ordering of prescribing, administrating, and monitoring of medically assisted treatment. These components of the prescribing, administrating, and monitoring can take place on a variety of sites. So it's not just opioid dependence with treatment in a medically assisted treatment in the NCPs. It expands, and again, to buprenorphine, naloxone, and disulfiram. These are the ones available at this time. Some counties may also choose to utilize the long-acting injectable naloxone, and of course, this has to be a provision in their ODS application. Recovery services are an important component, and I would say especially in this continuum of care. The recovery services and also case management, next part, are kind of the glue that help to evaluate, stay connected to, and move beneficiaries through these levels of care appropriate to their clinical needs and their desires at that time. Recovery services are services that are provided generally when a person completes a program. And again, completes is not a time-limited completion. They've met treatment goals to indicate they can discharge from that level of care. And they're ready to move to either another level of care or frequently, which is the goal, this whole thing, this whole system of care for individuals to progress to a point to where they're at self-sustained, community-based recovery. Self-sustained, not meaning they need to do it on their own, but that the support system for their continued recovery is much under their own self-management with support in the community itself. So recovery services are that may include a little bit of outpatient counseling in terms of trying to stabilize the beneficiary at times, not necessarily provide treatment, but if they're hitting a rocky time and need an hour or two to talk to someone at a counselor level, maybe assess them for coming back into the system of care. That's their recovery monitoring, coaching in a way. Oftentimes that could be, depending again, the county gets a lot of license in how they design their recovery services program. But you can see with recovery monitoring, which may be even coaching over the phone, if that's in their design, is a way to try and keep contact and connection with the client with recovery services. Assistance, peer-to-peer services may be included, and much in support of case management, trying to connect people to education, jobs, skill, family support, or support groups is included in recovery services. Case management is a particular function in which counties coordinate the case management services because the counties are responsible for coordinating the care of case management services, which is to ensure that beneficiaries have a comprehensive assessments and reassessments, that they successfully transition to higher or lower levels of care, that they're monitoring beneficiaries' progress and act as a patient advocate to linkages for physical and mental health. So case management services in some counties are very strong in terms of the counties doing case management services. Some may design in a way where providers will take on some of the case management services, but it's a very global look in net, more than just recovery services of if this person staying connected to, integrated into the system of care in the county, and to support them doing that. Physician consultation services are a specific service where a county may have one or several identified physicians or possibly a pharmacist to provide consultation to medical directors or medical staff in programs on particularly difficult cases. And this is on a case-by-case basis. These services, the MHC, the medical assisted treatment, recovery services, case management, and physician consultation are required. I'm not sure if there's any questions yet. That was a lot of material right there. But if there are, make sure you type something in and we'll let me know if there's anything. Whoops, pardon me, I went back one. I think I saw a question here. Let me just stop for a second. Let's see, at level 3.1, the SGC requires 5 hours a week of clinical service. Under Title 22, the regs require 20. What is the difference between clinical hours and structured activities? Well, your structured activities, sometimes structured activities may be peer-led, or they may be led by someone who is not a certified alcohol and drug counselor. There's somehow your support staff in your agency, and they don't fall under the category of a licensed professional or a certified alcohol and drug substance use disorder treatment staff. Billable hours to drug medical need to be provided by qualified staff, and the staffing for that needs to be professional licensed staff, and I'll talk about who's with what professional licensees. I've got a slide that shows a whole list of licensed people can do that, or needs to be the non-professional staff would be registered certified alcohol and drug counselors that are in compliance with Title IX. So you could have a number of activities but unless those activities are provided with the professional or the registered certified staff, then it doesn't count in the 20. I hope that answers that question. Initial medical necessity, and everyone who for payment in drug medical or drug medical ODS, medical necessity must be established, and this is performed through a face-to-face review. And it says for telehealth by the medical director, licensed physician. And the face-to-face, there is seen, it could be with the beneficiary, but it's meant to be a face-to-face review between the counselor who conducted the assessment and the, again, medical director, licensed physician, or licensed practitioner in healing arts. I've got a slide that will give you the whole list of who's a licensed practitioner of healing arts, and it's kind of just check the box on the list. The face-to-face may include the client. There was recently a webinar by Department of Healthcare Services which talked about this very point, and they said in this webinar, and it's on one of their slides, that this their interpretation of the face-to-face was face-to-face, or it could be a telehealth, again, with the counselor who conducted the assessment. They're very clear. It can't be just Counselor Y who has the assessment in front of them and wants to talk to the doc. It has to be the counselor who conducted the assessment. So this face-to-face, again, can be literally face-to-face, or it looks like it could be telephone telehealth. And this must happen. What are they reviewing? Well, they're reviewing the ASAM assessment intake data to see if they can determine medical necessity. And let me get over here. You probably should add medical necessity is, and it's not on this slide, but that's the one you need everyone to know. It is a medical, a DSM-5 substance use disorder diagnosis. If it's a youth under the age of 18, it could be an individual who is at risk of having a substance use disorder diagnosis. And most of the at-risk factors, I would want to have, and I see the county contracts with various providers and their drug medical ODS waiver information really pretty specifically says what identifies at risk. We'll make sure you have local clarity on what at risk would be. So again, if you're over the 18 or over, you need to have the DSM-5 diagnosis. And also you need by ASAM criteria impairments that would require treatment. And treatment is generally provided for other than convenience, meaning that for the person to improve functioning, that treatment would be appropriate and could be expected to improve their functioning. So medical necessity, again, diagnosis, and you have some impairments that needs that are identified within the 6 dimensions. Who can provide this medical necessity statement and determination? And when they make that determination, they not only have to say, here's the diagnosis, they also have to cite what is it that was gleaned from the assessment which supports this diagnosis. So it's real important in doing that ASAM that one identifies really not only pertinent issues, but what are diagnostically significant data. Who can do this? Number of licensed individuals or licensed eligible physicians, nurses, PAs, registered nurses, pharmacists, clinical psychologists, your LCSWs, licensed clinical social workers, marriage family therapists, professional clinical counselors, and licensed eligible practitioners working under the supervision of a licensed clinician. So it may be what would be an MFTI intern or LCSWI. These are the professional staff who can do the determinations for medical necessity. Counties may contract with the licensed professionals. They may have them on staff, and certainly we see more have them on staff again when we get to the 3.5 partial hospitalization, those more intense levels of care, which the clients require certainly more professional treatment for the impairments they bring to qualify for those levels of care. Registered and certified alcohol and drug counselors must adhere to the California Code of Regulations. And hopefully you keep your certifications up and do all your CEUs and have your employee personnel office staff make sure they have all of that information. This is one of the areas that gets reviewed on when the county or state comes in to do an audit. Non-professional staff, and that would be the registered certified alcohol and drug counselors, are required to have on-site orientation, training, and supervision by professional or administrative staff. This is fairly standard. Some operational requirements. Some operational requirements to come up. Really looking at, and this is the county when the counties get to determine under the ODS who they're going to have as providers. And certainly providers need to be licensed and certified by the Department of Health Care Services. But some of the other operational requirements which may come in, geographic accessibility. This easy in some areas where you have a long population density and good public transportation. Rural counties gets very difficult. I know Los Angeles County looks at when a referral comes in to try and make the referral within 30 minutes by public or private transportation or within 10 miles from the person's residence, or at least where they take residence. That would be really difficult in some other counties, but certainly looking, what this really addresses is as we try and not only engage people in a continuum of care and maintain them in that continuum of care until they can, let's say, successfully, again, self-sustain some recovery. You know, we look at how do we reduce the barriers to being in those, and accessibility by geographic is certainly one of the considerations and needs to be addressed in the plans and in the provision of modalities. Also, linguistic and cultural accessibility is a consideration, and what's noted on here are addressing the federal class standards, and these are 15 standards that can be downloaded. If you don't have them, I'm sure your county has them, which really talks about not only governance and leadership in your workforce, but communications and language assistance, engagement and accountability towards not only language in terms of written materials and spoken provision of services, but also any particular addressing and identifying and trying to provide services that fit in a cultural manner that is not only acceptable but engaging to the individual, and how in fact does your organization assess these needs on a regular and ongoing basis and then provide them. Disability access, mobility, visual and auditory is another consideration that in this continuum of care and the modalities that are offered, that these certainly need to be a part of the considerations of making sure that accessibility in terms of geographic, linguistic, and cultural, and for any mobility is provided to individuals. Along with that, and one of the strongest considerations is timely access to the appropriate care level. This is a fairly dense slide. There's a lot of points on it. But these are elements that would be in a county's application for the ODS to become an ODS opt-in county. These are also areas which are important not only to the county but to the providers, individual providers themselves. And this is going to be part of our evaluation of what's working and, quite frankly, what's not working and how we can improve it. And some of that has to do with access to care, the number of days it takes to receive a service, an appropriate level of care after referral. Most of what's talked about in the waiver is that it needs to be, certainly timely and prompt, and that this is especially true with the severity of someone's condition of how quick do they get in. And this accessibility, I'm seeing various counties have set time dates, I think, in for residential services, the time for a request for an authorization for treatment. It's one of the areas where you have to get authorization. An authorization request needs to come from the county within 24 hours. Frequently, what they're doing, let's say in various counties, are setting some standards from if there's a central intake or a central referral point. That there's frequently that once that referral is matched with a provider in the person's, let's say, geographic area, it fits for them geographically, possibly even culturally, linguistically, and that this referral needs to be picked up within, and an interview scheduled within 3 days, and the interview assessment provided with it needs to be scheduled within 3 and provided within 10. Regardless of what the specific timelines each county establishes, you'll need to comply with what your county says, and know that it's going to be really important, because one of the main evaluation tools is what are the numbers of days? Are people getting into services quickly? What's the number, the percentage of time period between authorization requests that are, whether they're approved or denied? And again, authorization requests really come for the residential treatments. Those are the ones where we limited to, say, 2 90-day treatment stays with an extension. So that service needs to be authorized. Outpatient services, no, you can just go in. However, still going to look at this would be, let's say, a county monitoring function, but they'll need to get the information from providers in some way, depending again on your electronic healthcare record, however it's set up, to look at even an outpatient. When did I get the request? When did the person get their assessment? Did they engage in services? All of these matters of did people get request services? When did they get assessed? When did they engage? How long did they stay? All of these points of service, engagement and service, and then moving through are going to be important to record and to keep for evaluation. And there'll be a slide on quality improvement. But by setting some standards and analyzing this, we'll get to see really if the levels of care and people's movement appropriately through these levels of care, what's facilitating that, what's being a barrier. And of prime importance also is the quality or the timeliness of service for the first dose of narcotic treatment programs, access to after hours care, there will be, and again, as I'm seeing with various counties, what contracts with the providers are requirements for, so let's say for an outpatient clinic, the hours they would want them to minimally be open and be responsive to calls. So again, it may vary with counties, but this responsiveness to access lines and timeliness is extremely important and an operational requirement for the county to do. And of course, that requirement falls down and filters down to the providers themselves. There will be some utilization management included within this, and utilization management is really looking at assuring that there's appropriate access and that medical necessity to the proper level of care, the appropriate level of care, and that medical necessity has been established that is appropriate for that ASAM level of care. That may be frequently at times when you look at say, what is the intensity of symptom presentation that would qualify for a 3.1 residential, and once that whatever it was that earned that person the qualification for medical necessity for that level of care, utilization management would say when that's resolved, and let's say it could be complications from a dimension 5 where they're incapable of maintaining any reasonable level of abstinence from continued use, and they've got a high dimension 2. They're having some liver problems and hep C that's undertreated or untreated, that puts them at risk. And say, oh, we can discharge them when? Well, when they're really, they've sought and are starting some medical care for their dimension 2, and they've demonstrated some efficacy at managing their compulsion to use. And oh yeah, we have them, they're willing to go into some transitional living housing out into the outpatient. Boom. Utilization management would say, are we assessing that and then managing that to move them through the system? Another operational requirement looks at our linkages with medically assisted treatment and communicate with prescribers. What this is does every provider have within their policies, procedures, and practices methods to assess someone for their interest in and maybe that they may benefit from medically assisted treatment? How is that offered? And if it is offered and accepted, what is the system that provider then gets medically assisted treatment services for that individual? And again, we talk about the seamless transition between the substance use programs, levels of care, and access to recovery support services. 3 critical linkages. I would add to those linkages the importance of linkages to primary care, mental health services. Excuse me, I have some beep on my phone. I hope that. Are there any other questions? If I could see if make sure you submit them in time. Otherwise, it's another dense slide. Sorry, these are so dense with information. But this slide really talks to, and this is more talking to counties rather than any providers, that if there is a linkage provision of a managed care program as a part of the county system, that there needs to be linkages to physical and mental health and MOUs, not only with the managed care, but again, with physical and mental health. These MOUs or memorandums of understanding really speak a lot to how do those parts of the system of care in the county, how do they engage each other? How do they communicate with each other? What's the process for any case management responsibilities or sharing care plans, communicating, tracking referrals. Again, I think hopefully it's evident from this that not only does under the waiver want to provide various modalities of service for substance use disordered individuals, this needs to be really looked at a more finely meshed, I would say, safety net for individuals to fall through, and one that doesn't have the wide gaps that not maybe willfully, but just have been evident in our system of care before, where it was sometimes really even difficult to move somebody from residential into an outpatient program. The more we can look at our system of care and say, how can we move people more seamlessly and include the other behavioral and physical and mental health services, then we're meeting not only the spirit or the demands under operational requirements, but the spirit of the waiver. A very key issue in evaluation is quality improvement. Utilization review, we kind of covered and said utilization review really talks to are the services that we have in our continuum being utilized in a way which has maximum effectiveness for the client, for the individuals being served. Are they being underdosed, overdosed, not receiving treatment in a timely way? Are they staying engaged? Quality improvement really must, and it says quality improvement must monitor. Now these bullet points here come from when it says T&C. These are the standard terms and conditions, the agreement between the state and the CMS, the Federal Center for Medicare and Medicaid Services. And they've said, counties, you need to monitor the timeliness. Again, access. What was that amount of time from the initial contact to that face-to-face appointment? And again, looking at 7 days would be looking at the outside. Generally 3 days, 1 to 3 days you want for that. Number of days for the services at the appropriate level of care. Here we're looking at generally 7 to 10 days would be considered, I would say, the standard. Earlier, if the person has some severe impairments that really their life would be in peril if they didn't engage quicker, you may lose them. Access to after-hours care. These are when I say these are nodes that will be monitored. Data will have to be collected on all of these areas, and the county will be providing reports to the state. So if these are data collection points, if you're a provider, you're also going to say, I'm part of providing the data. How is it in my system? Is it, maybe it's I put it in electronic healthcare records, it's held by a county. Maybe it's not. Again, electronic healthcare records and records vary from county to county, but know that these are going to be the important points. You will, as provider, be looked at from the county to say, I need this data. So it's everybody's issue. The county has a responsibility, but programs have a responsibility to have their quality improvement also. So access to after-hour care, responsiveness of the beneficiary to an access line. If you have an access line or after hours, your responsiveness, meaning provider, to maybe the access line from the county, and you get a referral. Interesting enough, strategies to reduce avoidable hospitalizations. There's a countywide strategy that we would probably look at individual programs that may, how do you monitor your clients who have adverse events or who start to decompensate in treatment? Maybe they get worse. How are these managed and what interventions are brought in to maybe try and recognize earlier when someone may develop a problem that could involve hospitalization. This could be like psych hospitalization, and how is the care plan developed to try and avoid that happening. And of course, the coordination of mental health primary care. The assessment of the beneficiary's experience, there is required out of this, and some of it gets standardized into a review by the beneficiaries, your clients, who go through a review of your program and their assessment of their experience in treatment. So again, number of percentage people denied, and how long the time period from authorization request to that approval. So these are 2I. And when it's quality improvement, understand a part of the quality improvement plan, and this gets looked at the county level, but also at the provider level. When you have quality improvement, it's not just collecting the data and providing the information so that there's a nice document that says, well, here's how we're doing. There really needs to be, say, in areas of timelessness for initial contact, a number of days to the first appropriate level of care, identify any problems with access or treatment, and that you have sometimes thresholds saying, if I get people going past 10 days, it triggers a study and report. So, and it not only triggers a study and report, your quality improvement says that you have some body within your program, a quality improvement body which says we've recognized that we're not meeting our threshold for timeliness of our first face-to-face appointment, and you quickly institute a plan and you evaluate that plan to see if you get improvement. So this quality improvement is not just monitoring. It really needs to be looked at, and it is looked at in the waiver as providing monitoring, identification problems, and quickly, not waiting for maybe your county or the state to come along and say, well, you need to improve this, and we want to see a corrective action plan. No, have an ongoing quality improvement program. And you may use the same quality improvement if your county is mental health. Your 2I committee, this is for the counties, must meet at least quarterly and have written minutes. I would recommend that providers also meet at least quarterly, have written minutes. If you identify some issue in a plan, and this is a word, NIATX, N-I-A-T-X, you can Google it up, as a wonderful tool that for training, providers can access and learn strategies to quickly and manageably, even in the smallest agency, identify what may be some problems and do quick action and quick assessment turnaround plans to improve quality of care issues. And of course, utilization review. County may look at medical necessity. If I'm an agency, it's somehow I'm going to be looking at medical necessity, because the truth is, if I somehow am providing services to someone under drug Medi-Cal, and at some point their medical necessity would be viewed as not present, maybe enough issues are resolved that they're not meeting the criteria, and I continue to provide services. I get a monitoring review. It's very possible that there could be recoupment of those funds, and I would lose revenue. So it's really important not to just rest all of utilization review and review of medical necessity on a county, but for the fiduciary responsibilities of each and clinical responsibilities of each agency to have some way to review that, which brings in the appropriate ASAM level of care and interventions as appropriate. UCLA has a program evaluation. This is a large slide which talks about that, and you can, if you're a county, I'm sure you know about the UCLA program evaluation, that you can integrate with. And if you're a provider, please talk to your counties about using this. And notice the key part of this is comparison of ASAM indicated versus the actual level of care. We really do want to assess this because some ASAM research so far has really supported the hypothesis that if we have levels of care and we assess people for their appropriate level of care, that if they get engaged in that appropriate level of care, they'll have a better outcome. And research by using the ASAM tool has supported that hypothesis. And so what happens as we build these systems of care and move into it, there may be places where we have gaps. Where we have some 3.1 but not 3.5. We generally don't have 3.3s. We may have difficulty accessing the medically monitored and medically managed levels of care. Accessibility may be an issue in some areas. So there are gaps in services that are going to exist, and sometimes our most expensive and most, I'm going to say, precious levels of care, the ones that we don't have many of, and that would be residential beds, could become not accessible. Or some clients may even say, I'll go to outpatient, but I won't go to residential. And we end up people get put in levels of care which are not a match for what the ASAM indicated. And actually, well, you want to evaluate these, not only in terms of a gap in service, but because it may support needs that we could look at some resources and try and fill. But also how is it in our county that how good of a job are we doing of getting a match between what is indicated and what the person actually receives. For gap assessment, we could use quite a few items. We could use surveys, electronic surveys, numbers of requests for services, track special populations. Again, look at these ASAM indicated, ASAM received. What was the reason for that? Tracking what are the reasons. And in this first 3 years, and I'm somewhat familiar with what's called an EQRO, the External Quality Review, which is mandated by the federal government that the county or states who receive these waivers to Medicare, Medicaid, have an external quality review. External meaning it's not Department of Health Care Services people who will go and evaluate the services provided, and their evaluation is quite extensive, and it will involve, when they need to come annually to counties, and they will talk to them. They're not going to really evaluate providers except through the county filter, although they may come to providers and come to consumers and do focus groups. And what I like about this, the attitude on this is not so much, it's not a punitive one of let's catch you in the things you're not doing well. It's more, let's evaluate and see if there's ways to improve and bring in information even from other counties on what's working right and what are they doing. But there's going to be a huge effort to compile information, and this information, not only for quality, but looking at gaps, may come up in solutions on how we can fill them. Solutions could include things, the geomapping, to look at locations and modalities, and geographic areas, and see if there's possibilities that we're seeing. Geographically, we're getting a lot of requests for services from an area and there's not a provider there. How could that gap be filled? But a constant kind of information flow and monitoring and assessment and a solution finding for gaps. They may be culturally and linguistic, that And again, you see in the second bullet point, the EQRO measures what's called penetration rates for special populations, and that may be an area where you have a large, more homogeneous ethnic population in an area, and you've assessed in some ways that there may be substance use problem, but when you in that area, maybe appropriate to what we see in the county, but we don't see those individuals accessing treatment. So their penetration rate, the penetration for services into that group is very, very poor. They've got a problem, but they're not getting help. And we want to look at that, say that how could we overcome whatever barriers, linguistic and cultural, that are blocking their access. Surveys of staff and providers, you know, do we match the communities in which we're serving? And disability access, there's a couple of tools which are available to assess your sites, your particular sites for for accessibility, and I would encourage anyone to kind of download those tools to look at like ramps. When do you need a ramp? What would be the declination of the ramp? Where I've gone through some facilities, and they're not old historic, but where you don't have door handles that can be opened with closed fist. There are a number of things, but having a good survey tool to look at your own accessibility issues and make sure you're compliant, I think, is important. And there's co-occurring disorder capability. ASAM has a classification for what they call co-occurring disorder capable programs, and those are programs that address co-occurring mental and substance use disorders and their policies and procedures. Their assessment and treatment planning and their program content contains information about co-occurring disorders. And the programs have arrangements for coordination and collaboration between addiction and mental health services. They can also provide medication monitoring and some screening oftentimes, or even a psychological assessment consultation on site. Generally, the program staff in a co-occurring disorder capable program are able to address the interaction between the mental health and the substance use disorder and their effect on the patient's or individual's recovery. There's a step up in that in terms of co-occurring enhanced programs, are programs that address the co-occurring mental health and substance use disorder in their policies and procedures, but also they accommodate patients who have both an unstable co-occurring mental health disorder and substance use disorder by providing those symptom management and treatment services on site. There's this more than oftentimes a close collaboration that the integrated services are provided in the one program. But some programs are just substance use disorder specific. I think being able to know what you are you, and if you say you're co-occurring disorder capable or enhanced, look at the ASAM definition and ensure that you're truly co-occurring disorder capable or enhanced. Timely access to care. I feel like I've beaten on this for a while, but it's a big issue. And again, being able to monitor that, measure it, track your referrals. Tracking of referrals will frequently be a case management, maybe at a county level, at a provider level, the ability to track your referrals and do some follow-up rather than can be put into your recovery services plan and services. When you look at filling gaps, This again, from some surveys, they could be access, demographics, geographic. You see what facilities are needed. Can you expand existing footprint? And trying to look at program expansion, it's really, really difficult. The cooperation between, and the cooperation not only in terms of resources, but information between counties and potential providers can assist in the whole idea of filling gaps. It's easier with outpatient services, that's certain. Residential services, it's very much tougher. There's a challenge in looking sometimes in expanding services when you have a residential and you're looking at building and developing a campus, maybe adding outpatient or intensive outpatient things. So you're going to keep knocking on the door of licensing and certification to say that maybe the idea of having recovery campuses hopefully is not a dead idea, that we can have those. So, you know, even in good geographical areas that are very accessible in terms of culturally, linguistic, and geographically, and disability access, that if some required service like an intensive outpatient could be easily put onto a campus of a residential, I hope we can start looking at how we can do that. Sometimes we have to look at out-of-county partnerships. I know there are some of those geographically wide but not densely populated counties. Let's say in Northern California or places in Central Valley, you really have to look at expanding and say, how would you provide services through partnerships? And there's a partnership in Northern California going on with a number of counties that is very promising in being able to coordinate services across county lines. And again, especially for services that are sparse, expensive, and without partnerships would be difficult, if not impossible, to access. Another gap could be qualified staff, and this is a huge issue, especially for the LPHA, the licensed professionals, and how we can sometimes, it said we could contract with LPHA, so how we share that resource, physicians, communicate even between providers to be able to share those resources, because again, we're a continuum of care, this idea of being just kind of an isolated provider. Hopefully that doesn't persist. And how can we move clients, again, not only through our level of care, but have these, I'm going to say, precious and scarce resources shared, can help us do that. Staff training and requirements. All agencies are required to have at least 2 evidence-based best practices, motivational interviewing and cognitive behavioral are 2 of the most frequently used, and that you have not only training and training availability, looking at resources, and I think one of the later slides is about the various resources that can provide training to your staff, and I would say ongoing training with motivational interviewing, in particular trauma-informed services. Motivational interviewing meant the Motivational Interviewing Network of Trainers has really done some good research around what does it take to be trained in MIT. And they've seen 2 6-hour trainings with 4 booster sessions is minimal to get change in counselor-provider behavior, meaning their use of MI. So we need to not only look at this as an ongoing issue, not only that someone's got some training, but they're competent to be able to provide and document services that are consistent with either motivational interviewing, cognitive behavioral, relapse prevention, or trauma-informed. So that involves doing a staff training needs assessment, which could fit in anyone's quality improvement program. So, and in some areas, it's with that EQRO, the External Quality Review requires counties to have what may be called a PIP, Performance Improvement Plan, and sometimes training and improving staff can be a part of a performance improvement plan. But this involves ongoing review of personnel and not only their qualifications but their ongoing training. What are their needs and how are those needs being provided? More with mental health, QI monitoring. So when we fill the gaps and we look at how urgent and emergency services, how are these being provided, it's really important that immediate treatment in network is provided. And what is immediate? Generally for an urgent emergency service, we're looking at 24 hours. And if it's incumbent, if the county can't provide it, that they seek those services out of network or out of their county and provide the service and pay for them until it can be provided in their county. Residential treatment authorizations, again, these require an authorization, and are they being provided in a timely way? Are we tracking approvals and denials and reasons for that? Timeliness of the first NTP dose, what would be a standard for timeliness, and what would be an emergency service in that? Again, having standards set in these, what would be in your county that you track not only how quick did someone get in, but did they meet what would be your thresholds for good timeliness? And unique to SUD is looking at the coordination of physical and mental health services. Not only are people getting referrals, I would add on this physical and mental health, know that in the physical body, but also dental comes in that and is an important part. Is it assessed? When people have an assessed issue of under-treatment or lack of treatment, lack of access to care, do they not only get a referral, does the agency that's doing the referral, have they tracked that referral and the engagement in those services? Services that are not covered include clean and sober housing, residential room and board, early engagement, people if you're doing readiness groups, maybe services for undocumented persons. So these may be a gap, and counties certainly get to look and say what might they use, what fiscal resources, some maybe this would be block grant monies, other monies, county general funds, whatever you have available that may need to be used to cover these gaps. And certainly clean and sober housing and residential room and board are key funding issues. And other county resources that were identified as your program monitoring staff, medical director, and your access lines. It's required to have this 24-hour access line, and then who monitors the access line that responds to it. Training and technical assistance and policy assistance. This could be a gap. Who connects with the HCS and statewide organizations? I can say as a recommendation, I've fallen out of my practice on this. I can say weekly, I like to go onto the DHCS website and look at the notices and bulletins and see if something's changed. Because frequently, unless you go onto the DHCS website, dhcs.org, and look at the bulletins and notices, you can lose track of a key change in what's being an interpretation or a new area that should be attended to. Again, and finally, we can always look at writing grants. These are ways to fill the gaps. Secure loans, startup facilities. frequently counties are not doing that, but counties may write grants, but this is always, we live by the grant and die by the grant, but it can really help out these times of looking to fill gaps or develop regional programs. And again, there's one I know of called Partnership in Northern California that's a really good model for developing regional programming contracts. This was a slide on overcoming the difficulties, and there are a couple of good websites for legal issues and impact to recovery and facilities and good neighbor guidelines. I would have you hold on to this, and if trying to establish a site and integrate it into your community, these are great resources for you to do that. And know that we have a 3-year phase-in implementation for the ASAM levels 3.1, 3.3, and 3.5. And we always be looking at this QI data on, again, on our timeliness and appropriateness of ASAM levels of care, and saying if gaps are cited as some of the issues affecting timeliness and the ability to provide appropriate ASAM levels of care, this is a gap, and that's where we go and say, how can we fill this gap? Internships, student loan forgiveness, anything we can do to pay raises. Anything, I'm sure anybody in the especially in the certified alcohol and drug portion would welcome that, and look at any strategies to improve data gathering. And I would say any ways you can do this in non-duplicative fashions that honor the time it takes to sometimes do this. And so this is a real systems issue. And there's some people really, really good at identifying resources to gather data and not reduce redundancy. Bill put on this, my friend Bill Manoff, put this slideshow together, and Bill identified, he was really, really good at identifying resources. And so federal and state grants, he was a master at grabbing those. But also looking at criminal justice and human services, CalWORKs, the AB 109 monies, any other FQHC types of provision of some support, not necessarily in terms of grant funding, but to be able to provide services. These are areas that we can look at to fill gaps that may be evident in our system of care. Other strategies, CIBHS does drug medical ODS trainings. They help provide this webinar, which I hope some of this information is useful. They also will be providing any ASAM trainings that counties may need, and sometimes other non-ODS, say, trainings on confidentiality and on, let's say, various best practices, motivational interview, cognitive behavioral. That's always good to go on the CIBH website, see what may be available and what you can bring to your group. This was developed by Bill Manoff. We're pretty close to time. I didn't see any other questions come up. And I would hope that if you have other questions, that maybe there's a follow-up way we could filter those in. And I hope this was useful. I want to thank you for your time, and hope your day is wonderful.
Thank you so much, Jan. And we do have 4 minutes left of the presentation time, so if anyone does have any burning questions that they didn't get answered, or any other questions on any of the content, please do submit them now in the questions box, and we can allow a couple more minutes for that. And as we're getting wrapped up, we just want to thank Jan so much for his time, and as you exit the webinar, make sure to take our survey. Oh, and also the handouts. If you didn't receive the email, you can download them from the handout section in the GoToWebinar control panel. We'll just wait a couple more minutes here to see if there are any other questions. All right, I do have a question here, Jan. I'm sending it your way.
Okay, see if I can. Let's see if I can see it. Oh, I see it is detox certification provided by DHCS or by another entity, and it's by DHCS, and it's their licensing certification branch is what I understand. So you would contact them about certification.
And we do have one more question, Jan, that I sent over to you.
Mm-hmm. Okay. Let's see. Okay, discuss how QI will capture strategies to reduce avoidable hospitalization or utilization review. As I understand, this is going to be something that they'll look at from the, again, the EQRO, the external quality review, and it'll be more in the quality assurance than the utilization review. It will be a quality assurance node, data gathering node where they may look at clients who are in the system, and then how many clients in the system or beneficiaries in that system may be needed to access or be hospitalized. And then it's kind of a retroactive looking into some of those files and kind of saying, was there anything that could have been done to reduce that? Do people, meaning in the countywide system or in their programs, do they have anything which would say policy and procedure to recognize when someone may have a profile, and I'm going to say it's a profile which may put them at risk for hospitalization. This, one of the things that you might say, what would that be? Well, if we look at an individual who had a history, where they took their ASAM, that they had a history of frequent ER visits, and what was the nature of those ER visits, and say they're precipitated around some medical conditions that were being untreated or undertreated, and certainly the comorbidity of the substance use disorder put them in places where they were at risk for those hospitalizations. And you might say, is the treatment plan and the treatment addressing aggressively enough those factors that you could say is really pointing at trying to avoid those? So that becomes at that level a QI function that's within the program, and then that information would be accessible to maybe QI at a county level. And then the investigation into that may get triggered by, are we having a high number of rehospitalizations of high-risk patients? Are we identifying high-risk patients in the category they have frequent rehospitalizations, and are we aggressively enough treating them? So that's kind of how, so it's more QI than utilization.
All right, we do have one last question here that I'll just go ahead and read to you. This individual says that you seem to say that 5 hours of clinical time for residential 3.1 is determined by the credential of the person providing the structured activity. Is this correct?
Yes. Yes, it's drug Medi-Cal services. All reimbursable drug Medi-Cal, and that's drug Medi-Cal ODS services, have to be provided by qualified staff. Qualified staff are licensed individuals and or certified alcohol and drug counselors. So if you had an activity, and it could be a structured activity, and it's not provided by that one of those qualified staff, it by that definition becomes not billable. So it couldn't count towards your 20 hours.
All right, great. Well, thank you for all of those questions, and thank you, Jan, for your presentation. With that, we will conclude our broadcast. Thank you again for joining us.
Thanks. All right. Bye.
Bye-bye.